To all, and welcome on this pre-Diwali weekend to this interesting and different web event. All of us are now silently, gradually, slowly moving and gearing up for the fortnight celebrations. But before we take a break from our routine for the festivities, which we have been looking forward since a very long time, let's delve into some academics and also in a very interesting and different way. When we talk of teaching sessions, usually it's that there's a teaching session and this is followed by some form of an assessment or a quiz or something like that. But today we are going to turn the things around. First, it's the quiz. So all of you will be answering the questions and then we will be teaching. Not only that, along with the different pearls that you will take home from the discussions and from our experts, you might also be lucky enough to take back home not only one, two, three, or a few or some prizes, but loads and loads of prizes today. So get your brains working hard and your fingers clicking fast, as today will not only it will matter that who is the most intelligent or who is the most well read, but it also matters that who is the quickest to respond. So without wasting any more time, let's get the game rolling. I'll first share the rules of the session and the quiz with you. So the rule number one, without which the entire session will not be of any use to you, you have to be registered on this number. It was already shared in the flyer. You still have this on your screen, 992 0003981 with your name and address. Because unless we are able to identify you, we'll not be able to pick you up as a winner. And unless we have your address, the gift will and the prize will not be delivered to you. So make sure that you're registered on this number. Rule number two, we have 7 topics, 7 experts with us today, and 3 MCQs per topic. You'll have 15 seconds to be given to answer each question. Don't right away while you're reading the question, start responding on that number. After every question, you will have a pointer like, in KBC, Amitabh Bachchan says, "Aapka samay shuru hota hai ab." So something like that, your time starts now. So only after you hear the now, you can start your responses, and we'll be keeping a note of the time as well on our end. Rule number 3, the winners will be selected on the basis of fastest finger first. Of course, the accuracy of the answer is of utmost concern. Without that, fastest finger makes no sense. And we'll have 3 winners per topic, 1 for each question. There is just a first winner for each question, no second, no third, no runner-up. And because we have 21 questions, we'll have 21 winners in the entire session. The winners will be announced at the end of every session. So once an entire topic like say cornea or glaucoma or whatever it's over, the winners for that session will be announced. All the winners will receive their prizes for which we are very thankful to from Centaur Pharmaceuticals Private Limited. Before we move on to the actual session, a small trial run. I'll just display a small question and let's see how we can work out and you can understand how the system will work. So the question is, who killed Bahubali? A. Shivagami, B. Devasena, C. Bhallal Dev, or D. Katappa? And your time starts now. Mitali, can start the timer for this.
Yes.
You have to send your answer on that WhatsApp, the telephone number that was registered. Yeah, your time is up. And we have collated all the responses. The correct answer is, of course, Katappa. Katappa ne Bahubali ko kyun mara? So, right, so that's how the system will work. And after this, we'll go on to the next MCQ. So this is how the entire session for today will be working. And let's meet our experts. We have the Satya Pe Satta team. Of course, this is, I just renamed it because we are 7 of us. The stalwarts we have today are far from this notorious gang. They are very dignified, cool, calm, and knowledgeable persons. And these are the ones. I'm sorry, Shell, for posting you over Shakti Kapoor, but I found an uncanny resemblance between those two pictures. And me, of course, far from being Amitabh Bachchan. So this is our team. And to keep the entire Satya Pe Satta team in line and seeing that the entire web session runs on time, flawlessly, without any deviations, there's somebody always to control everybody. So we have our two moderators, Dr. Gunjan and Dr. Jignesh, will be taking charge of the entire session and maintain the flow of the session. So with that, let's move on. I hand over the session to Dr. Gunjan and Dr. Jignesh, and we can move with the first session. Thank you and all the best to all the participants, and let's have some learning and earning as well.
Good evening, everyone. So we are now starting with our quiz media. I wish all the very best to all the participants. Our first speaker is MSDNV. She has done her fellowship in cornea and refractive surgery from Nagari Eye Hospital. She is a fellow of Shankar Nethralaya, Chennai, and she is a key learner with constant zest to acquire new skills. I welcome Dr. Gunjan Shah to start with the quiz. Over to Dr. Gunjan. Is it visible?
Yes, it's visible, Gunjan.
Okay. So hello everyone. Let's start the quiz.
Ma'am, you can make the slideshow, please.
Yes. So, is it okay now?
Yes, ma'am.
Okay. So, I am Dr. Gunjan. I will be asking cornea questions. So, let's start the quiz. Here is the first question. So, which of the following is not an iron deposition line in cornea? Ferry's line, Kayser-Fleischer's ring, Hudson-Staley's line, or Stocker's line? Your time starts now.
Time up.
Now move on to question number 2. Gunjan Didi, should I move on? Next question.
Yes, go to the next question.
Okay. So the question number 2 is, all of the following are contraindications of SLET surgery. SLET stands for simple limbal epithelial transplantation, except keratinization on the ocular surface, conjunctivalization of cornea, dry eye, or disorganized anterior segment. Your time starts now.
Time up.
Okay, the third question is, irrespective of the etiology of corneal ulcer, the drug which is always indicated is corticosteroids, antibiotics, antifungals, or cycloplegics. Your time starts now.
Time up.
So let's move on the discussion of these questions. So the first question was, which of the following is not an iron deposition line in cornea? So as we all know that Hudson-Stahl's line is an iron deposition line in the corneal epithelium, which commonly seen in the junction between middle and lower one-third of the cornea. It is the junction where the both lids meet when we close our eyes. It is most commonly seen in elderly, and it has not very much of clinical significance. Kayser-Fisher's ring is seen. It is due to copper deposition in the cornea, and it is usually seen as a golden brown ring in the peripheral cornea. It starts at Shalby's line and extending less up to 5 mm onto the cornea. The ring may be greenish yellow, ruby red, bright red, or ultramarine blue. It appears superiorly and then inferiorly, and later it may be circumferential. And Stoker's line is seen at the head of pterygium, and Ferry's line is seen at AGS black. Kayser-Fisher's ring, also known as KF ring, it is seen in Wilson disease. That is due to defect in copper metabolism. Fisher's ring is seen in keratoconus. The question number 2 was, all of the following are contraindication of SLET surgery except keratinization, conjunctivalization, dry eye, and disorganized anterior segment. So the answer is conjunctivalization. As we all know that limbal stem cells are located at the corneal stem cells are located at the limbus. So when there is damage at the limbus, that may be due to chemical injury, uncontrolled VKC, extensive OSS, and Stevens-Johnson syndrome, the limbus may get damaged, and conjunctival epithelium may grow over the cornea, and it may cause this conjunctivalization. So LSCD means conjunctivalization means LSCD, that is limbal stem cell deficiency, which forms an indication of stem cell transplantation. However, this keratinization or severe dry eye, disorganized anterior segment, or unattended adnexal pathologies, they forms the contraindication for stem cell transplantation. This surgical technique was first described by Dr. Sangwan in 2012 for the treatment of limbus stem cell deficiency. In this surgery, a 2 by 2 millimeter strip of corneal limbal tissue was obtained from the healthy eye and divided into 8 to 10 small pieces. After surgical preparation of the recipient ocular surface, these tiny limbal transplants were distributed evenly over an amniotic membrane placed on the cornea. So this SLET may be autologous or allogenic. And the contraindications are dry eye, blind eye, disorganized anterior segment, perforation or adherent leucoma, anterior staphyloma, or there is uncorrected adnexal pathologies. They are contraindicated. So this was the question number 2. The question number 3 was, irrespective of the etiology of corneal ulcer, the drug which is always indicated is corticosteroid, antibiotic, antifungal, cycloplegic. The correct answer is cycloplegic. So because steroids are indicated in shield ulcer, marginal keratitis, disciform or stromal viral keratitis, and this antibiotic are specific in bacterial infection. Antifungals are given in fungal infection, but cycloplegic is to be given in each and every case of keratitis to relieve the ciliary spasm and to prevent the formation of posterior synechia, which may be associated with the iritis accompanying bacterial keratitis. So thank you so much, Purvi ma'am, Gunjan Didi, Jignesh bhai, Mitali ben, and the entire team of Centure for giving me this opportunity. Thank you and wish you a very happy Diwali. Thank you.
Can we have the results now for this session, Mitali?
Hitendra, please share the slides.
So the winners for cornea session winners are question number 1
the winner is Dr. Pallavi from Hubli. And for the question number 2, Dr. Arushri from Patna. And for the question number 3, Dr. Pallavi from Hubli. So it looks like residents from Hubli are there doing a great job. Very well done. Congratulations. Okay, thank you so much.
I think from the next session, we should have something like, one who has already won a prize is not eligible for a second one.
Yes, ma'am.
Okay. Yes.
No. Well done and congratulations. And we can move on to the next session. Dr. Gunjan and Dr. Jignesh, you can take over.
I congratulate all the winners. And where are the other people? Only Hubli people, not fair, right? So one small thing that we register over 90% of the total incoming information with our eyes, and this occupies almost half of our brain. So just do some brain exercise and start doing. Now we'll invite our next quiz master. He is working as associate professor in pediatric ophthalmology department at MNJ WRIO. He has done his WHO fellowship from Madurai. Also short-term training done at AIMS and ROP training at LV Prasad. He is an ICU awardee. He has done pediatric ophthalmic fellowship at Germany. He is also double doctor, so he has done PhD in childhood blindness and low vision in Gujarat State in 2012. He is appointed as advisory member for management of pediatric cataract by Ministry of Health and Family Welfare. He has worked as chief ophthalmologist for National Survey of Childhood Blindness by Ministry of Health and Family Welfare, Delhi. He has held various posts of executive committee of Ahmedabad and Gujarat Ophthalmological Society, and he is very much interested in teaching and is always eager to teach. And he is very expert in refraction, especially in pediatric surgery. So I invite and I welcome Dr. Kalpit Shah, sir. Sir, please continue with your session.
Thank you, Gunjan, for kind introduction. It is actually more than what I deserve. Is it visible?
Not yet.
Not yet.
Not yet, sir. Not yet.
Now?
No.
Still not?
No, not yet.
Network something.
Visible?
Not yet visible.
Yeah, just wait for 1-2 minutes, I think.
Yes, now visible. It shows started screen sharing, but slides are not yet visible.
Yeah, slide still slide slow. Huh? Yeah, fine.
No, not yet visible. The screen shows sharing, but slides are not visible.
I think network is slow.
From my side,
Maybe a lag in the network. Yes.
Okay, visible.
fine?
Yes.
Yes, sir, visible.
Okay. So we start with the first question. Like in this picture, what could be the possibility of having a squint due to which muscle? So Either it could be acquired LS left superior oblique palsy, myasthenia gravis, congenital right superior oblique palsy, or congenital left superior oblique palsy. Your time starts now.
Time up.
Okay, now we move on to second question. On looking at this diplopia charting, which muscle could have a paresis or palsy? It is purely horizontal diplopia. So it could be either right medial rectus, right lateral rectus, left lateral rectus, or left medial rectus palsy. Your time starts now.
Time up.
Thank you. Now we move on to the third question. Like a patient age of 4 years has 15-degree esotropia. The refraction under atropine coming as like shown here in the slide. Distance performing the retinoscopy is 1 meter. So what would be the prescription if we want to give in a minus cylinder form? +5 spherical, plus 1.5 cylinder at 150, plus 5.5 spherical, minus 0.5 cylinder at 60 degree, plus 6.5 spherical, minus 1.5 cylinder at 150 degree, and plus 6 spherical, minus 0.5 cylinder at 150 degree. Your time starts now.
Time up, sir.
So now, should I start with the explaining the all answers? Ne?
Yes, sir.
Okay, fine. So in the first slide, the first question was that which muscle could be the affected one. If you see in Levo version, like here, when looking at the Levo version, the right eye is not exactly coming into the center, but it's going up. So it looks like right eye inferior oblique overaction. In Levo depression, the left side depression, the right eye is not moving down. So the muscle which could be responsible for moving the right eye in Levo depression could be affected one. Now here looking at this skull's morphology, you can see here on right side there is a plagiocephaly. If you compare the frontal bossing on the both side, the right side there is some depression on the skull. That is like here you can see the frontal bossing. Here that could be a plagiocephaly. So what happened because of the congenital plagiocephaly? She had the right eye superior oblique underaction, and because of continuous right eye superior oblique overaction, she would not have diplopia if she tilt her head towards the left side. So she keeps all the time her head towards the left side, and because of that the left side face is looking as a facial asymmetry. The left side face as a something facial contraction. So because of that plagiocephaly, she had a right eye superior oblique palsy, and because of the right eye superior oblique palsy, she was keeping all the time the head tilt towards the left side shoulder, and because of that the left side face is not developed properly. So this was the answer, like right superior oblique palsy. Now the second slide. Now that regarding the diplopia, the first we have to see that which type of diplopia is there. So already I have given the clue that it is a purely horizontal diplopia. Now we have to see in which gaze that diplopia is maximum. So here you can see the diplopia is maximum in left gaze. So in left gaze, the horizontal muscle which are acting is either left lateral rectus or right medial rectus. So this is very clear. Now, so left gaze, there is a maximum diplopia. So it could be either left lateral rectus or right medial rectus could be the affected one. Now we have to see that which type of diplopia is there. Here you can see the dotted arrow that belongs to right eye, and the solid arrow that belongs to left eye. So right eye image is on the left side, the left eye image is on the right side. So it is a type of cross diplopia. If the solid arrow was on the left side, then it could have a uncrossed diplopia. So the cross diplopia suggests there could be a exotropia. So out of these four muscles, either left lateral, left medial, right lateral, we have filtered that two muscles could be affected, one either left lateral rectus or right medial rectus. Now if the left lateral rectus could be affected one, then there should be esotropia, and esotropia would have a uncrossed diplopia. Now the remaining one, that is a right medial rectus. So if we suspect the right medial rectus palsy, the maximum diplopia is working in which the right medial rectus muscle is acting. So that is in Leo version. So left gaze. So left gaze, there is a maximum diplopia. Again, it is a type of cross diplopia. So right medial rectus affected, that means there could be exotropia, and exotropia have a cross diplopia. So the answer could be right medial rectus palsy. Now the third one. Here we have to take the clues which has been given already. Like here there is a esotropia. So in esotropia we want to give the full correction. Means we don't want to deduct the effect due to the drug. So as you all know, the atropine has an effect of +1 and the distance is 1 meter. So if there is no esotropia, there is no screen, so we would deduct +2 from the refraction. But here there is a esotropia, so we will deduct only the +1. That is because of the distance of 1 meter. So we have to deduct +1 from the given refraction. Now the question is, we have to prescribe in minus cylinder form. So for the minus cylinder, we have to take the spherical which is having a maximum plus refraction. So here the +7.5, that is higher than the +6. So +7.5 we have to take as a spherical. So now we deduct +1 from the 7.5. So +6.5, that is a spherical. The cylinder remains the same. So cylinder is -1.5. So +6.5 spherical, -1.5 cylinder. Now the degree we want to give at the vertical level. So 150 degree will give the effect at the 60 degree. So the right answer would be +6.5 spherical, -1.5 cylinder at 150 degree. That's all. Over to Gunjan.
Yes, sir.
Can we have the winners of this session, please?
Hitendra, please. Hitendra, please share the slides.
Please, sir, announce the result. Kalpit, sir.
Yeah. So all are from Gujarat now. This is the turn for Gujarat. I think Gujarat has a. This shows that we have taught in a proper way that pediatric ophthalm. So for the first question, the winner is Khushi Shah from Ahmedabad. For the second question, the winner is Dr. Sanket Oza from Gandhinagar. And for the third question, the winner is Dr. Kaumudi Sinde from Bhavnagar. Congratulations for the all winner.
Now you can stop your screen share.
The slides, sir.
So I think it's time for now North and South people. So I'm about to introduce our very own and our dear head of unit. She is associate professor and head of glaucoma unit at MNG WRIO. She has more than 40 publications and 120 presentations. Her field of interest are glaucoma, medical education, and research. She is awarded with prestigious FAMER fellowship. She has also various prestigious leadership positions in local, state, and national societies and committees. So there is an n number of committees she have in her armamentarium. She is past principal, School of Ophthalmic Science at MNJ Institute. She is in editorial board of IGO and various other journals of repute also. The awards given to her as an outstanding work as a woman in WAS 2015. Role model of the year was 2016. A coin gold plaque for best equestrian in 2016. A coin secretary silver plaque 2017. Leadership award was 2017, and she's also felicitated for contribution in ophthalmology in 2018. And I think her motto is whenever you want to give something, give your 100%. That's what I learned from her. And I welcome Dr. Purvi Bhagat ma'am to continue with the quiz.
Thank you, Dr. Gunjan. And yes, you rightly said, and I would like to re-emphasize on that again. It's been my WhatsApp status for a very long time that unless and until you're donating blood, for all other things, always give your 100%. So congratulations to all the winners. And before I move on to the actual questions, a universal question of the COVID era, am I audible and are my slides visible?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Yeah, thank you so much. So moving on to the glaucoma section, the first question, which of the following is not a factor to be considered while setting the target IOP for a patient? Is it A, age of the patient, B, systemic status of the patient, C, socioeconomic status of the patient, or D, is it family history, which is not to be considered? And your time starts now.
Time up, ma'am.
Yeah. So the time is up for this one, and we move on to the second question. You can see some structure. So identify the structure which is seen on gonioscopy. The arrow is already there. Is it A, peripheral anterior synechia, B, goniosynechia, C, pseudosynechia, or D, is it an iris process? And your time for this starts now.
Time up, ma'am.
Yeah. And moving on to the last question of this segment, name this sign. The arrow is there. So which vascular sign is it? Is it A, bayoneting, B, barring of the circumlinear vessel, C, overpass phenomenon, or D, is it a lamellar dot sign? And your time for this last one starts now.
Time up for this question.
So while the results are being collated and we identify the winners, let's understand what the answers are and why they are so. So the first question, which is not to be considered while setting the target IOP, it is the socioeconomic status, which is not to be considered. So basically, talking of target IOP, what is it? It's a range of intraocular pressure levels within which the progression of glaucoma and the field loss can be delayed or halted. It's not a single numerical value or a fixed value. It's a range and which is very dynamic and ever changing. So how do you set the target IOP? Which are the factors to be considered? The first and foremost is, of course, the initial IOP when the damage has occurred. If the initial IOP is very high, say the patient presents to you in the ranges of 40s or 50s, then perhaps you can do with a high target IOP in this patient. But if the damage has occurred at a low target IOP, or low intraocular pressure, say normal tension glaucoma, then in these cases, you need to have a low target IOP. The second factor to be considered is the age, which was one of the options in the MCQ. So age and life expectancy. If the patient is elderly, having lots of other health issues, comorbidities, not likely to live very long, then in these cases, you can do with a high target IOP. But if the patient is young, likely to live a very long and active and healthy life, then in these cases, you need to have a low target IOP. The third is the damage when the patient presents to you. If it is a case of mild glaucoma, less severity, then you can do with a high target IOP. But if it is a case of advanced glaucoma, then you need to have a low target IOP in all these cases. So these are the primary factors which influence your decision of a target IOP. But there are other factors also. One is how rapidly is the progression occurring. If it is faster progression, then again in these cases, you need to have a lower target IOP. And there are certain other risk factors to also to be considered. Then you need to have a lower IOP. So which are these other risk factors? One is a thin cornea, African and Asian races, family history. This was again one of the options, especially when there is a history of visual loss because of glaucoma or failed surgery, complications. In all those cases, you need to be aggressive in your management and follow-up. If the patient is myopic, what is the status of the fellow eye, especially if the other eye is lost because of glaucoma, one-eyed cases, and systemic status, because certain systemic diseases we know, like diabetes, hypertension, others, they tend to increase the progression of glaucoma. And how do you set the target IOP? According to the American Academy guidelines, which we follow, if it is a case of mild damage, you have to reduce it 20% from the baseline. If it is a case of moderate glaucoma, you have to reduce it 30% from the baseline. And in cases of advanced damage, there has to be reduction of at least of 40% from the baseline. And in normal tension glaucomas, you have to reduce it 30% from the baseline, and ocular hypertension, reduce it 20% from the baseline. So this is how you decide your target IOP for a patient. Coming to the second question, the answer was D, that is, these are iris processes. The most common errors which occur during gonioscopy interpretation are because the technique is faulty and we have not actually done it properly. That is why we interpret it wrongly. So it is very essential that to diagnose it rightly, you have to first do an external examination and slit lamp examination. Much of the clues of what you will see in gonioscopy can be derived from a simple slit lamp examination also. For example, in uveitis, you might expect pigmentation and synechia. In pseudoexfoliation, again, you might expect pigmentation or even PEX material in the angle and so on. Always perform tonometry before the gonioscopy, because the moment you put the gonio lens, the angles are tend to either artifactually narrow down or they may open up because of the pressure, and you may have false IOP levels. So always perform your tonometry before the gonioscopy. Use the correct lens and the correct technique and the lighting conditions. We all know it has to be done in a dimly lit room. The two common mistakes which we make in gonioscopy are the pigmentation and regarding the processes and synechia. So pigmented Schwalbe's line, as you can see here, it is usually mistaken for a pigmented trabecular meshwork. So you see this, you assume it is trabecular meshwork and you label it as an open angle. So how will you distinguish? If it is discontinuous and salt and peppery type of an appearance, like you can see here, all this irregular, patchy, then that is a pigmentation on the Schwalbe's line. But here you can see it is a continuous, confluent, uniform band-like structure. So that is actually a trabecular meshwork. So that was the pigmentation and this is the meshwork. So that is how you identify. And the second common mistake, as I said, is between processes and synechia. So what are processes? They are fine, thread-like fingery projections which extend just till the scleral spur. They follow the concavity of the iris and do not obscure the structures. As you can see the angle structures between and behind the processes. They move with indentation, and if there is angle recession, they may be broken off. Prominent iris processes can be seen in congenital glaucomas and classical cases like Axenfeld's anomaly. Synechia, on the other hand, peripheral anterior synechia, they are broad-based. As you can see in this below figure, they extend beyond the scleral spur. They bridge the concavity of the recess and actually close the angle. You can see here that the angle is actually closed. On the sides, you can see the meshwork, but here you cannot see. And they resist any kind of a movement and trauma. If it extends till the scleral spur, such a synechia is known as a goniosynechia. If it extends beyond, it becomes a peripheral anterior synechia. And what are pseudosynechia? They are simple bumps or elevations or irregularities in the iris surface. So you feel that these are synechia. But the moment you do indentation or manipulation, these disappear and you can normally see the angle. So these are known as pseudosynechia. And the most important thing when you're doing the gonioscopy to avoid any of the errors, make it a habit of actually interpreting from the iris anteriorly. What you see here, this black line, that is actually the rim of the gonio lens and it is not the trabecular meshwork. So always form a habit that you go from the pupillary border to the iris and read upwards. For this, you can remember the mnemonic, I can see till Schwalbe's line. So I is trace the iris, C, can you see the ciliary body band? Then S is for the scleral spur, trabecular meshwork, and Schwalbe's line. So go anteriorly accordingly. And the last one, this sign, the answer was B, that is barring of the circumlinear vessel. So whenever you see a glaucomatous disc, what are the things you examine? Their size and shape of the disc, the CD ratio, the neuroretinal rim status, the position of the vessels, and the asymmetry or symmetry between the two eyes. You see for the vascular signs and you see for the peripapillary signs. In the vascular signs, these are the signs which are seen. In many patients, you have these kinds of a vessel which actually follow the margin of the cup. They are kind of a circumferential vessel which is known as a circumlinear vessel. Now, when the cup enlarges, glaucomatous changes develop. What happens? The cup enlarges but the vessel stays there. So this becomes barring of the circumlinear vessel. You can see here, this is a circumlinear vessel and it has become barred from the margin of the cup. Then you can have overpass phenomenon. That is, a vessel is just bridging, simply bridging across the center of the entire diameter of the disc. When the cup deepens, this vessel falls into the floor of the cup. So it appears as a bridge, which is known as an overpass phenomenon. Or you can have a classical bayoneting sign. Bayonet, basically the word comes from the army rifle, which has a dagger at 90 degrees. So on the top there is a rifle and on the bottom hand there is a dagger. So just like that, at 90 degrees there is a deflection of the vessel. You just feel as if the vessel is coming from nowhere. So this is a classical bayoneting sign. And of course you can have nasalization. There could be narrowing of the arteries near the disc or generalized also, and there could be tortuosity of vessels, or there could be collateral vessels or even anastomosis in response to the chronic ischemia that may occur in these cases. Okay. And in glaucomatous disc evaluation, always remember that whatever signs you see, the classical sign should be of neuroretinal rim excavation. It is a classical diagnostic sign for glaucomatous changes. Just measurement of the CD ratio alone is insufficient. When you talk of cupping, do not use color difference to distinguish the cup edge. It is the change in the direction of the blood vessels that marks the cup. And the disc abnormality, it is without being said, it is understood that they should always correlate with the field defects. If not, then either of your interpretation or examination is incorrect. And the size of the cup always appears smaller if you are seeing it monoscopically. And stereoscopic view using a 78 or 90D lens is the best way to see glaucoma changes. Thank you. And with that, we come to the end of my session. And Mr. Hitendra, if you can share the results for this one. Yeah, glaucoma session. So the first one, Dr. Hetal Patel from Valsad, Dr. Sneha Shah from Bhavnagar, and Dr. Snehal Naik from Ahmedabad. Wonderful. And again, Gujarat is leading, and we are proud of this. And because this is a question of fastest finger first, rest assured that there has been no leaking of questions, because it's not only your knowledge, as I said, it's also your ability to respond fast that matters. So thank you all. Congratulations to the winners, and moving on to the moderators for the next session.
So humans and dogs, one small thing. Humans and dogs are the only species known to see visual cues from another individual's eyes. And dogs only do this when interacting with humans. So if anyone is angry with you, you can just see in their eyes and you can know that, oh, this person is angry. So that's just for fun. Our next speaker is a very dear friend of us. He is DO, DNB, FRCS, FICO. He is working as a cataract and refractive consultant in Raghudeep Eye Hospital, Ahmedabad since January 2014. He has done his fellowship in cataract and cataract surgery and phaco in Raghudipai Hospital, and also he has worked as a prestigious Moran Eye Center in Salt Lake City, USA. He is trained in general ophthalmology at LV Prasad Eye Hospital. He has won many accolades for his academics. He has more than 10 peer-reviewed publications and is a reviewer in one of the prestigious journals. He has been awarded a Best Paper at ASCRS 2015 and received the grand prize for the best of the best among scientific videos submitted to Film Festival in ESCRS 2019. So I welcome Dr. Shail Vasavada. Sir, please, you can start your quiz.
Thank you very much, Gunjan, for the kind introduction. Gunjan and me have been colleagues all through, so it's flattering to hear from you, Gunjan. I think it's such a wonderful way this meeting has been conducted, and I think credit must go to Purvi Madam for coming up with this wonderful concept. And I must say I have learned so much already. So although you may feel you know the answers, when the reasons are given out, we often feel that this is not the reason why I chose the answer. So I think it's very important that this format is followed by the explanation to the answers. And true to my photo, which Puri Madam showed, I'll be keeping it light and simple, as Shakti Kapoor would do. I acknowledge the support of my colleague, Dr. Shrishti, in preparing these questions. The first question is a surgical scenario. So you have posted a patient who has been diagnosed to have a posterior polar cataract. And we know that there is a surgical complication which is more commonly occurs in a posterior polar cataract compared to a normal cataract, that is posterior capsule rent, which we all fear. So all of the following steps can be done to reduce the chances of complications, except. So one out of the four options should not be done in a case of posterior polar. And amongst them, option A is hydrodissection, option B is hydrodelineation, option C is a closed chamber technique of phacoemulsification, and option D is minimum lens rotation. Your time starts now.
Time up, sir.
Okay, so now we move to the second question. Just have a look at this video. This is very familiar to all of us who do cataract surgery. Keep looking at the iris here, and the iris has started prolapsing once we have injected fluid into the anterior chamber. So the question is, which of the following is not a factor for causing iris prolapse during a routine, so-called routine cataract surgery? A, the patient who is taking systemic alpha agonist medications. B, a poorly constructed side port or main port. C, high positive posterior pressure or vitreous pressure. And D, patient taking systemic alpha antagonistic medication. So which of this is not a factor for iris prolapse? Your time starts now.
Time up, sir.
Okay, so we move to the final question. This is regarding the various refractive surgery procedures that are available today to our armamentarium. So this is a 23-year-old male patient, and he has the following eye parameters. So his refraction in both eyes improving to 6.6. In the right eye is -11 with half a diopter of cylinder, and -11 with a quarter diopter cylinder in the left eye. His axial length is appropriately high, 28.84 in the right eye and 28.5 in the left eye. If we look at his corneal evaluation, there is no irregular astigmatism as can be seen on the corneal scans. And when we look at his keratometry, his K1 is 42.2 at 22 degrees and K2 is 42.5 at 5 degrees, which corresponds to the minimal astigmatism that the patient has. The thinnest pachymetry of the patient is 502 microns, and the anterior chamber depth is quite deep, which would be expected in a myopic individual. The left eye also has a very regular cornea, no gross asymmetry in the cornea in the anterior as well as the posterior curvature. The K1, K2 are 42.5 and 43 with the thinnest pachymetry of 504 microns and the anterior chamber depth 3.83, which is again deep expected in such a patient. So the question is, which refractive procedure would you choose, or would you suggest for this patient? A is either a LASIK or PRK or surface ablation. Second is B, that is SMILE. Third is a posterior chamber phakic IOL. And fourth, or D, that is clear lens extraction. Your time starts now.
Time up, sir.
Okay, so until the results are collated, let's go to the answers of each questions. So the first question was which surgical maneuver you should never do in a case of posterior polar cataract, and the answer is the simple hydrodissection, which we sometimes do as a reflex. So you must always remember before you start the case that this is not the case when you want to do your next step as hydrodissection after capsulorhexis. And that is because if you raise the intralenticular pressure, so this is the capsulorhexis, when we inject fluid, it causes an increase in the intralenticular pressure, and the posterior capsule in a posterior polar cataract is very weak, so it can easily rupture just when a fluid wave passes from one end to the other, and therefore the preferred technique is to do a hydrodelineation. This can be done conventionally or in this way known as an inside-out delineation, where you first create a sculpting and then through the sculpting inject it. So there is no chance of the fluid going subcapsularly or affecting the posterior polar part, which is very strongly adherent to the posterior capsule with a thin posterior capsule. And you must always maintain a closed chamber technique. And what do we mean by a closed chamber technique is never allow the chamber to shallow. So even in this case, after doing a sculpting, when I want to inject or do hydrodelineation, what I will do is I will never pull out this phaco probe suddenly. By doing that, the anterior chamber collapses, the lens iris diaphragm moves forward, and that pressure difference alone can cause the posterior capsule to rupture. So always inject dispersive viscoelastic or methyl cellulose from the side port to make sure that the chamber is well formed before you actually withdraw your phaco probe. So this is an extremely important step in a case of posterior polar to keep in mind. The second question, which of the following is not a factor for eyelid prolapse during cataract surgery? And from MCQ general knowledge, I think it would be easy to guess that it has to be either one of either A or D, because both are opposing each other. And the answer is a patient taking systemic alpha agonist medications. The patients taking actually systemic alpha antagonistic medications, they tend to commonly used for prostate medications and bladder problems. They relax the smooth muscles. And by doing that, it also relaxes the iris dilator muscles by binding to the postsynaptic nerve ending. So what happens is that typically a patient taking alpha antagonistic medications, the pupil is preoperatively always dilated about 6-7 mm. And as soon as you start your surgery and the steps keep going on, the iris continues to start prolapsing. So the important steps to keep in mind in such a surgery is to first make sure that your wound construction is good. So if you have a very short incision, there is a very high chance of the iris to prolapse. Like we often see in SICS, if there is a premature entry, the iris always prolapse. So always have a long incision, relatively long, a rectangular incision, where the distance between your external and the internal incision should be at least 2/3. So if you have a 2.4 millimeter knife with which you are making an incision, the distance between the external, that is the limbal entry, and the internal, that is the corneal entry, should be at least 1.8 to 2 millimeters for it to be a good self-sealing wound. Another important step in patients with intraoperative floppy iris syndrome, or IFIS as it is called, is to make sure that you do not use a very high bottle height. So if you keep a very high bottle height, the fluid will go we have a mindset that if there is a small pupil, we must increase the bottle height. It actually works reverse. In a small pupil, if you increase the bottle height, the fluid will actually go behind the iris and cause further iris prolapse to keep a lower bottle height than what you would do normally. So these are a few steps to keep in mind to make sure that the iris doesn't prolapse during surgery, particularly in a patient who's taking alpha antagonistic medications, which is very, very common in the geriatric male population, particularly many of whom have prostate medications. So in your history before cataract surgery, in all patients, particularly in all male patients, make sure you ask them if they are on any prostate medications. And even if you stop these medications few days before the surgery, it will have no change in the effect of the iris. So once a patient has taken alpha antagonistic medications, he will continue to have the effect. And the common one are tamsulosin, terazosin, chlorpromazine, so on and so forth. So keep in mind the patient taking prostate medications. The third question was the points to look at for choosing a refractive surgery. First is you need to look at the refractive error. So keep in mind, this is a high refractive error and a very long axial length. The second thing we want to look at and rule out is if there is any irregular astigmatism or any cone shape or keratoconus kind of features which are absent in this anterior float of the pentacam. The other thing that you need to look at is the anterior elevation or posterior elevation, which means this is basically derived from a hypothesis that if you put a best fit sphere on this cornea, how many points of the cornea are above it and how many points of the cornea are below the best fit sphere. So this is the anterior float of the graph. So any value more than about 12 to 15 is considered as a high risk for developing post-operative ectasia. And similarly, in the posterior float, anything more than 15 is considered to be a high risk factor. The other factor that we need to look at is if the keratometry is too steep or too flat. So any keratometry beyond 47 or 48 is suspicious of being keratoconic. So keep that in mind. I'll explain the role of pachymetry and the anterior chamber depth. So in this case, the factors to keep in mind, the answer is C, a posterior chamber phakic IOL. And that's because when you compare the amount of magnitude of refractive error you need to correct to change the cornea in LASIK or PRK or SMILE, what we are doing is we are removing some part of the cornea. So you have to deduct about 12 to 14 microns for the amount of diopters you treat. So for one diopter that you treat, you lose about 12 to 14 microns of the cornea. You must keep in mind that your residual stromal bed thickness after LASIK should be minimum about 280 microns. So in this case, if you consider the patient has 500 microns of pachy as an average, you remove 110 microns for the flap, that leaves you with about 390. And then for 11 diopters multiplied by say 12 or 13, that would leave you with less than 280 microns of residual stromal bed. The second important point to keep in mind is the post-operative keratometry that the patient will be left behind. Every diopter that you flatten of refractive error, there is a reduction of about 0.8 diopters on the cornea. So if you have an average keratometry like in this case of 42, and you deduct about 11 diopters from it, you will be flattening the cornea by about 9 to 10 diopters, which will be left behind, which the patient will be left behind with about 33, 34. Any post-operative flat keratometry less than 35 diopters can cause an extremely poor quality of vision. And if LASIK is not possible for ICL or phakic IOLs or posterior chamber phakic IOLs, an important consideration to keep in mind is the anterior chamber depth, not from the epithelium, but from the endothelium. So the ACD or the anterior chamber depth that we see written on the machines is measured from the epithelium to the anterior lens surface. For ICL, we need it from the endothelium to the lens surface. For that, we need to, it has to be more than 2.8 millimeters. So those are the questions. I hope most of you must have got it right. And over to Mr. Hitendra for the winners. So the winners are Dr. Pallavi R from Hubli. I think she's going to take home at least 50% of the prizes in this quiz. Many, many congratulations. I wish I was as smart as you during my post graduation. Dr. Tejal Garasia from Gandhinagar and Dr. Nilesh Paraskar from Ahmedabad. So congratulations to all the winners. I think this definitely is clearly showing that students in Gujarat are now getting better at multiple choice questions, something which we were very bad until a few years ago. So congratulations once again to all the winners.
Thank you so much, sir. It is a great presentation and important question and data explanation, which is useful in the future for the postgraduate in the private practice also. So now move towards the next one. Just some interesting fact. So our eyes can differentiate more than 10 million colors. I think someone knows or someone not. So next move to the next specialty. She is a DOMS MRCO, currently director and consultant at the Eyesight Retina Center, Ahmedabad, India. She is done fellowship in ophthalmology at Coventry, Warwickshire Hospital, membership of the Royal College of Ophthalmologists at London 2006, various publication and presentation at the national and the international journals, special mention award at the third annual Indian ROP Society meeting 2018, best of the best scientific paper at GOS 2012 and 2014. So now I invite the Dr. Silpi Shah to carry on next vitreoretinal specialty. Please, ma'am, share your screen and move forward.
Shilpi ma'am.
Yes, yeah. Thank you so much, Dr. Jignesh, for those kind words. Can you see my screen?
Yes, ma'am, we can see.
I can't see. Good evening, everyone, and thank you, Dr. Purvi Ben, for this unique opportunity to be part of an interesting teaching and learning experience. So without wasting much time, we'll move on to the retina section of the quiz. And here's our first question. A patient with the following fundus lesion shown here is at risk for developing option A, cystoid macular edema, option B, choroidal neovascularization, option C, retinal detachment, and option D, hypotony maculopathy. Your time starts now.
Time up, ma'am.
All right. So we move on to our next question. A 34-year-old male with visual difficulty in both eyes who had history of LASIK surgery done 6 years ago for -7 diopter myopia. His likely diagnosis looking at this fundus picture is option A, disciform scar due to myopic CNVM, option B, toxoplasmosis, option C, macular dystrophy, option D, myopic chorioretinal atrophy. Your time starts now.
Time up, ma'am.
Okay, let's move on to our last question. A 62-year-old diabetic male presented with history of corona, who was recently admitted, and about 2 weeks later, he complained of a sudden onset blurred vision with black patches in front of his right eye, and the vision was down to counting finger 1 meter. His likely diagnosis, looking at this fundus image, is option A, chorioretinitis, option B, vitreous hemorrhage, option C, choroidal neovascular membrane, option D, retinal artery occlusion. Your time starts now.
Time up, ma'am.
Okay, let's move on to the explanation while the results are being compiled. So our first question was this fundus lesion. As you can see, there is a hypopigmented curvilinear fundus lesion going through the fovea here with surrounded retinal and subretinal hemorrhage, which is most likely a choroidal rupture. And people with choroidal rupture are at increased risk of future choroidal neovascularization. So as we know, choroidal rupture is a break in the choroid, Bruch's membrane, and RPE, as shown in this OCT over here with this red mark, which is spilling in the acute phase blood into the subretinal space and surrounding edema. Most likely cause for choroidal rupture is blunt trauma. As we know, blunt trauma can affect the globe in multiple ways, starting from the anterior, you can have hyphema, cataract, subluxation or dislocation of the lens, angle recession, and going on to the posterior segment, it can have vitreous hemorrhage, posterior vitreous base avulsion, retinal dialysis or retinal break, or choroidal rupture or optic nerve avulsion. The choroidal rupture is, as we described, a classic curvilinear lesion, generally around the disc area. It is associated in the acute phase with retinal, subretinal, and or vitreous hemorrhage. The vision generally improves once the hemorrhage clears and the edema settles. However, the final visual prognosis will depend on the location of the rupture relative to the fovea, as well as the presence of the sequelae such as choroidal neovascularization and subretinal scarring. Our second question was this fundus lesion in a fairly young myopic male. The answer here is a macular dystrophy. Now, this is quite bilateral symmetrical scars to be due to myopic CNVM, and it's more of an atrophy. So generally, the geographic atrophy or disciform scars are not this symmetrical. And again, for toxoplasmosis, to have this bilateral symmetrical foveal scar is unlikely. And myopic chorioretinal atrophy is generally more diffuse, affecting the overall posterior fold rather than this circumscribed. So this is a picture of a North Carolina macular dystrophy, which is fairly rare form of a macular dystrophy, autosomal dominant, and with a link to a locus on the chromosome 6q called MCDR. It generally has a bilateral symmetrical fundal appearance, and it can range from a few small drusen-like lesions to a larger confluent lesions, or going on to grade 3 in, as shown in this picture, like a macular colobomatous lesion. You can see the OCT here. It looks like an optic disc excavation. There is almost colobomatous and herniation of the tissue. There's hardly any retinal tissue left over there. And distinctively, ERG and EOG are relatively normal in NCMD, this North Carolina macular dystrophy, unlike other macular dystrophy where there is more generalized retinal dysfunction. So which are the more common macular dystrophy? Stargardt's disease and fundus flavimaculatus, which is characterized by a beaten bronze central atrophy with variable degree of peripheral yellowish white flakes, which are more prominent on fundus autofluorescence as seen over here. And a typical OCT with foveal thinning and especially loss of the outer retinal layers. Second, more common is the Best disease or adult vitelliform dystrophy. Again, it is characterized by a classic yolk-like lesion at the fovea, which then goes into vitelliruptive stage. And in this stage, there is a classic homogeneous hyperreflective material in the subretinal space. And going on to our last question, this diabetic male had a post-viral chorioretinitis. Now, retinitis has been documented in feline and murine model infected with coronavirus, but has not been reported so far in the humans as far as I know. However, there is a distinct entity called post-fever retinitis, which is infectious or para-infectious uveitic entity described mainly from the tropical countries. And the onset is generally 2 to 4 weeks following the febrile illness with sudden rapid loss of vision. It has been described following chikungunya, dengue fever, Zika, Ebola, malaria, or even anthrax fever. It is generally typically unilateral or bilateral. It can be solitary or multiple patches of retinitis over posterior pole with exudation at macula. The top figure here shows post-dengue fever retinitis. Many times post-dengue, we see a lot of hemorrhagic retinitis, which mimic like a retinal vein occlusion as well. And the bottom picture here shows post-chikungunya bilateral chorioretinitis. Generally, majority of them have a favorable response to systemic steroids. And that's the end of it. Thank you very much. Can we have the results now?
Please, Hitendra, share the result.
All right. The winner of the first question is Dr. Jay Rathod from Junagadh. And for question 2, it's Dr. Chetana Karamata from Ahmedabad. And question 3 is Dr. Chintan Deja from Mumbai. Excellent. Congratulations to all winners. Very well done.
Thank you so much, ma'am. Such a nice presentation and covered the most important topic. Now forward to the next presentation. Next quiz master is she is working the assistant professor at the MNJ Western Institute of Ophthalmology, Ahmedabad. She did fellowship in the Orbit Oculoplasty and the reconstructive service from the Sankara Netralaya, Chennai. She is the young and dynamic oculoplasty surgeon. Please welcome the Dr. Ravija Katheria. Please, ma'am, start your screen.
You'll have to stop sharing your screen for me.
Okay, ma'am.
No, you're still sharing your screen. Okay. Okay, so now we'll start with the oculoplasty section of the PG quiz. We'll start with a fairly easy question. Please identify this stent. It has a collarette, a neck with a bulbous end, and it is a silicone hollow tube. It is approximately 30 to 40 millimeter in length. The options are A, Monoka stent, B, mini Monoka stent, C, Monoka Crawford stent, and D, Masterka stent. Your time starts now.
Time up, ma'am.
Okay. So we'll move on to the next question. Okay. Question number 2 is, an obese patient has chronic conjunctivitis with upper eyelids that easily evert. What additional feature of this disorder would you expect to be present? Okay. The eyelids, if you just put your finger or a earbud over the brow, the eye easily everts as shown in the picture. The options are A, history of sleep apnea, B, follicular conjunctivitis, C, tarsal biopsy showing decreased fibrillin, or D, history of hypoglycemia. And your time starts now.
Time up, ma'am.
So let's move on to the final question. This one's a googly. Identify who was the ophthalmologist who was also an athlete and was portrayed in the movie Chariots of Fire. Was it option A, Harold Abrahams, B, Sir Arthur Conan Doyle, C, H.B. Stallard, or D, Sir Harold Ridley? And your time starts now.
Time up, ma'am.
Okay, so now let us go forward with the explanations. So this stand with a collarette, a bulbous end, and approximately 40 millimeter in size. It's a mini Monoka stent. Monoka is a similar stent which is slightly longer in length, around 80 millimeter, which can canalicate both the canaliculus as well as the NLD. Then option C, mini Monoka Crawford, that is similar to Monoka, but it has an olive tip at the end. And Masterka is a preloaded stent that is available. So all these are monocanalicular stents which are used to keep the lacrimal pathways open. Mini Monoka is shorter in length and is commonly used in canalicular tear repairs, and it is a self-retaining stent. The technique is that you identify the proximal and the distal cut ends of the canaliculus under a microscope. Then a mini Monoka stent is placed, pericanalicular sutures are taken, and rest of the lid tear is repaired. Removal of the stent is usually done at 4 to 6 weeks. Earlier, it was done at 3 months, but now we can plan earlier removal. So this is how it looks once you have repaired. Only the collarette part is seen over the punctum. So this is the collarette which stays at the punctum, the bulbous end which stays in the ampulla at the junction of the vertical and the horizontal canaliculus, and because of this, it is self-retaining. Coming to next question, an obese patient with chronic conjunctivitis with upper eyelids that easily evert. This indicates that the patient has floppy eyelid syndrome. So in such patients, it is very important that you ask for history of sleep apnea, as sleep apnea can have some serious consequences on the health. So you have to ask for history of sleep apnea and snoring. So floppy eyelid syndrome is characterized by chronic papillary conjunctivitis and not follicular conjunctivitis. There are easily everted floppy upper eyelids, and this is due to decreased elasticity of the tarsus. The associations include obesity, keratoconus, sleep apnea, and hyperglycemia. Follicular conjunctivitis, which was one of the options, is not expected in floppy eyelid syndrome, and decreased fibrillin, which was also one of the options, is associated with Marfan syndrome. The treatment of floppy eyelid syndrome is you cover the affected eye with shield at night so that there is decreased mechanical rubbing and decrease in the papillary conjunctivitis. And the definitive treatment consists of shortening of tarsus by removing a part of it, or you can do a wedge resection type of a surgery for the lid. And remember to refer patient to a sleep specialist for the sleep apnea. So the final question, ophthalmologist who was also an athlete and portrayed in the movie Chariots of Fire. The answer is H.B. Stallard. I think most of us have read his book, Stallard's Eye Surgery. So he had won bronze medal in 1500 meter race in 1924 Summer Olympics and was a very renowned British athlete. He had won this race despite of sustaining a stretch fracture. He was immortalized in the critically acclaimed 1981 epic British film Chariots of Fire, which was based on this Summer Olympics. Apart from the famous book, he's known for the pioneering work in radiation therapy for malignant eye disease. And he was also a member of Order of the British Empire. However, he died in 1973 from osteogenic sarcoma of hip, which was most likely to be caused by radiation induced, since he routinely used to carry unshielded radioactive plaques in his hip pocket as he went from hospital to hospital. Thus, ironically, malignancy of one of the bones that had helped him become a world-class runner and athlete was probably caused by radiation, the use of which had made him world famous as an ophthalmologist. Thank you. So, are we ready with the results now?
Hitendra, please share.
Yes, ma'am.
So, winner of question 1 is Dr. Kajal Kataria from Ahmedabad. Congratulations, Dr. Kajal. Winner of question 2 is Dr. Arushi from Patna. Congratulations to you too as well. And winner of question 3 is Dr. Hardika Sathwara from Bhavnagar. Congratulations to all the winners.
Thank you so much, ma'am, for the great presentation. Now move on the last. She is the working as the associate professor in the glaucoma unit at MNJ Western Regional Institute of Ophthalmology, Ahmedabad. She is the member of Institute of Postgraduate Student Committee Standard Treatment Guidelines. She is a member of local, state, national, and international ophthalmological society awarded by the Health and Family Welfare Department, Gujarat State MPCB on World Sight Day 2004. She has multiple publications in the various journals. She is keen to aware the people for the traffic discipline and the cleanliness. So please welcome Dr. Kamini Prajapati, ma'am. Ma'am, please share your screen.
Kamini ma'am, are you there?
Hello, Kamini ma'am.
I think she has some network issues.
No network issue. I'm just sharing my screen.
Okay, ma'am.
Sorry for a minute inconvenience. Is it visible?
Yes, ma'am, visible.
Okay. Is it okay?
Yes, ma'am.
So good evening, everyone. And first, I would like to thank Dr. Purvi Bhagat Madam and Centure Pharmaceutical for giving me an opportunity to take a part in this PG quiz today. My topic is on comprehensive ophthalmology. I'm not just nothing less than. Question 1. Identify the pathology. Options are A. choroidal detachment, B, retinal detachment, C, posterior vitreous detachment, D, retinoschisis. Your time starts now.
Time up, ma'am.
Okay. Question 2. Which parameter does the A-scan of ultrasound biomicroscopy show? Options are A, lens vault, B, lens thickness, C, anterior chamber depth, D, central corneal thickness. Your time starts now.
Time up, ma'am.
Okay. Question 3. Which OPD procedure to be done with these lens? Options are A, ND-YAG laser posterior capsulotomy, B, indirect gonioscopy, C, optic nerve head evaluation, D, ND-YAG laser iridotomy. Your time starts now.
Time up, ma'am.
Okay. So now we can have our question 1, identify the pathology. Correct answer is retinal detachment. Why it is retinal detachment? If you see on the screen, it is a thick cord which is attached at the optic nerve head. It is visualized in normal as well as in the low gain settings. It moves with the eye movement. It crosses the midline. It crosses the midline and limited anteriorly to the ora serrata. The echo amplitude is 100% compared to choroid and sclera. In retinal detachment D scan, if you decrease the gain, still you can see the detached retina. After movement is limited, and A scan shows high spike. If it is old retinal detachment, then you can have a macrocyst. If it is tractional retinal detachment, then it is concave or tabletop appearance, because when the scar tissue on the retina pulls it away from the eyeball, it shows the concavity. It is limited after movements. In exudative retinal detachment, you can see here, you can see the retinal detachment with the posterior segment pathology. If you have a giant retinal tear, that it may roll inwards and causing curled appearance. In choroidal detachments are paired, echogenic, convex band extended posteriorly from the ciliary bodies. The detachment of the choroid from the sclera is due to accumulation of the fluid or blood in the suprachoroidal space. It is limited by the strong uvascular attachment, that is ora serrata, vertex fins, and optic nerve. The A scan shows, you can see here, the M-shaped double peak. The choroidal detachment may be serous, hemorrhagic, or mixed. If it is serous, there may be a low intraocular pressure, hemorrhagic with increased intraocular pressure and painful eyes. And risk factors for the choroidal detachment are intraocular surgery, nanophthalmus, patient is on a blood thinners like warfarin, trauma, and inflammation. So always perform longitudinal, axial, and transverse scan in B scan. In kissing choroids, you can see these smooth domes, convex shape touching in the center. So that is the choroidal detachment. You may have a hemorrhagic choroidal detachment. With the choroidal detachment, you can see the blood behind, but you may have a retinal detachment as well as the choroidal detachment together. Posterior vitreous detachment. Posterior vitreous detachment is a thin wavy membrane. See in this picture, it is a sphinx vivid appearance. It is freely mobile hyperemic membrane, swirls away from the, you can see here, swirls away from the optic disc with the movement of the eye. It is best seen when you increase the gain. In retinal detachment, you have to, if you decrease the gain, then also you can see. But in posterior vitreous detachment, if you decrease the gain, you cannot see the posterior vitreous detachment. And as the patients move the eye, the flap will float back and forth. It may have complete PVD or incomplete PVD. Retinoschisis, it is a thin membrane, convex and smooth configuration, usually on the temporal retina of the hyperopic patient and very highly refractive with underlying, you can see here, the black area, that is anoic fluid filled space, and height of this moon doesn't decrease, means it remains stable on pressure or indentation. The question 2 was, which parameter does the A-scan of ultrasound biomicroscopy shows? If you do the ultrasound biomicroscopy and make a report, pass the vector in the central, then you have this type of structure. The cornea, the anterior chamber, and lens in the center. If you see the A-scan of the same format, then you have a 4 spikes. The first 2 spikes are of cornea, that is one for epithelium and endothelium. The last 2 spikes is of lens. So I have asked this area. This one is the endothelium spike and this is the anterior lens spike. So between these two is the anterior chamber depth. What is ultrasound biomicroscopy? It is introduced by Charles Palvin and Foster in 1990s. It is a high frequency, high resolution device which is non-invasive for anterior segment anatomy in detail. The field of view is 4 by 4 mm and you have a 50 micron lateral resolution and 25 micron axial resolution. The probe frequency is 35 and 50 megahertz. Now the 100 megahertz probe is also available. You may have a linear soft sleeve probe, which is very useful while doing the UBM in pediatric patients. So this is a short video of the UBM. After applying the topical lignocaine and the silicone cup with normal saline or viscoelastic solution, you can put the probe in the cup and 360-degree rotate it and see the images, and you can even record the video. What are the biometric parameters you are seeing on the UBM? Apart from these 3 parameters, you also calculate the relative lens position. Relative lens position is useful for suspect of the primary angle closure. You can even measure the lens vault. What is lens vault? If you pass the line through the 2 sclerals for horizontal line and the distance between the center of the line to the anterior lens surface point, that is the lens vault. And you can calculate the certain angle parameters. While doing the measurements of the angle parameters, you should know the scleral spur. Why is the scleral spur? The scleral spur is the anterior limit at the junction of the sclera and the iris surface. And the most anterior projection here is the scleral spur. While where the cornea ends and sclera starts, you may find the Swalb's line. So there are different angle parameters, that is angle measurement at 250 micron and 500 micron. You can measure the iris thickness at different level. You can have a trabecular ciliary process distance, etc. Indications, anterior segment anatomy in opaque media. In glaucoma, you can find out whether the patient has a congenital glaucoma or acquired glaucoma. In acquired glaucoma, you can have a type of the glaucoma. The iris, you can have a, what is the surface of the iris, contour of the iris, what is going on behind, like this is the case of malignant glaucoma. You can have a certain secondary glaucomas, like this is the silicone oil in anterior chamber and in the posterior chamber. You may have a concave iris configuration in pigment dispersion syndrome. In uveitis patient, you can also find, if you do the radial scan, then exudates near the ciliary body, that is pars planitis. You may have a membrane over the pupil, that is occlusal pupillae, and you may have a iris bombing. In cases of trauma, if you cannot see any structure on the slit lamp, you can find any altered anatomy, whether it is blood, it is vitreous, what is going on behind, that is iris, lens, ciliary body. The angle decision also can be made out very easily on the UBM, and you can find out the occult intraocular foreign body. In case of tumors, you can find the site, location, the measurement of the tumor, the echogenicity of the tumor, etc. You can even differentiate between scleritis and episcleritis. The post-surgery, suppose there is non-resolving corneal edema, you can find out whether the descemet detachment is there or not. In the case of phakic IOL, the status of the phakic IOL, the iris cyst. Post-trabeculectomy, you can find out the patency of the peripheral iridotomy, inner window is patent or not, and of course, the type of the bleb and the bleb configuration, as well as the whether any abnormality like subconjunctival fibrosis or not. The third question was, which OPD procedure to be done by this lens? The right answer is anti-Yag laser iridotomy. So this is, can you see this peripheral button? This peripheral button is of Abraham's iridotomy lens. The Abraham's iridotomy lens has a plus 66 diopter plano-convex peripheral button. What are the advantage of using these lens? It acts as a speculum. It gives magnified image so that you can focus well like this. You can see the video simultaneously. It requires less energy, minimize the corneal burns. In case, suppose there is a bleeding, you can give the compression with the help of this lens. You can stop the bleeding. So ultimately, it helps to reduce the axial expansion of the plasma and reduces the unnecessary spread of the damage. Indirect gonioscopy. Indirect gonioscopic lens are available in single mirror, 2 mirror, 3 mirror, as well as the 4th mirror. 4 mirror, you can use the 4 mirror in certain diagnosis of the glaucoma. The advantage of 4 mirror is to differentiate between the appositional and synechial closure by doing the indentation gonioscopy. Anti-Yag laser posterior capsulotomy lens. It is same plus 66 diopter lens, but it is a centrally placed, a central button. While in iridotomy lens, there is a peripheral button. As iridotomy lens, it stabilizes the patient's eye and minimize the intraocular lens pitting. So it exactly focuses on the posterior capsule, and we have a cruciate opening. Last is optic nerve head evaluation. Optic nerve evaluation has been done with the plus 90 diopter lens or plus 78 diopter lens, which is commonly used. With the help of this, you can have a stereopsis of the optic nerve head and macula. And there are certain correction factors with different types of the lenses and different types of the companies. Thank you very much and stay safe. Happy Diwali in advance. May I have a result now, Mitali?
Yes, ma'am. Hitendra, please share.
Please, sir.
Ma'am, you can stop. Yeah.
Yes, I am stopped. So now, the winners are question 1, Dr. Kamudi Sinde from Bhavnagar. Congratulations. Question 2, Dr. Hetal Patel from Bhavnagar. Wow. Second from Bhavnagar. Many congratulations. Question 3, winner is Dr. Vaibhavi Patel from Gandhinagar. Many congratulations. So congratulations to the winner and over to moderator. Thank you very much.
Thank you, ma'am. So I'm very much thankful to all our quiz masters. They all have taught us very basic things. I'm very much thankful to all the PG students who have participated, because without them, this is of no use. I'm very much thankful to the Centro team, Mitali, Mr. Niyamat and Mr. Hitendra for providing technical support as well as marketing and for providing prizes. Thank you very much. With this, we are concluding the session.
Yeah, I would just like to, before we go offline, I would like to thank the moderators for connecting the sessions very well and coordinating and actually being the Hema Malini of the Satya Pe Satta team, everything began on time and concluded on time.
Yeah.
And to the PGs, again, congratulations for all the prizes. I'm sure you all must be looking forward to what is on your way. But more important than that, that was just for fun. We just hope that you gained some information and, utilizable knowledge and pearls from all our experts. Because as Dr. Shail mentioned, it is not actually just important to know what is right. You should also know why it is right. So even in an exam, when you're answering your questions, you may just answer anything for the sake of, a fluke answer. But then you should be able to justify your answer. So that was our motto. And thanks again to the entire team, all the speakers, faculty, and Centur team, and the moderators, and above all the students for participating. Thank you,
so
Dr.
much,
Purvi.
ma'am. Thank you so much, all the dignitaries here, especially for Purvi ma'am for arranging and initiating this session. Thank you to Dr. Shail, Dr. Jignesh, Dr. Gunjan, Dr. Kamini, Dr. Raviza, Dr. Shilpi, Dr. Kalpit. And it is really amazing, ma'am, that having so many big names in one screen. And I'm getting so many messages on my screen right now from across India. We have circulated and everybody participated. Beyond 500 participants today in this session. When it is PG, it is really a magnificent number. And just like a knowledge feast, ma'am, we are really glad to be a part of this knowledge feast, and we're really happy that we could be in support to spread this knowledge through these dignitaries. Thank you very much to all of you.
Thank you. Thank you.
Thank you, Midan.
And have a great and safe weekend, everyone.
Thank you, ma'am.
Thank you. Same
Thanks.
to you.